Okay, I have a question for you, and I want you to be honest. When was the last time you felt a genuine, heart-pounding spark of excitement about a manual update?
Laughing. I'm going to go out on a limb and say never.
Right. I mean, it's not your phone getting new emojis. We're talking about a literal, dense, several hundred-page PDF manual.
The kind of thing you immediately archive.
Exactly. It's the terms and conditions of life. But, and stick with me here, today we're talking about a document that is, well, it's arguably one of the most significant updates in the medical world in over a decade. It changes lives, quite literally, even though most people will never read a single page of it.
It sounds dramatic when you put it like that, but you're not wrong. We're looking at the ACR BI-RADS v2025 manual.
Right.
And for anyone who works in imaging, or honestly, anyone who's ever had a mammogram, this book is basically the Bible.
It dictates everything, and the context here is king. The last time this Bible got a full rewrite was way back in 2013.
Which in tech years is essentially the Stone Age.
It really is. I was thinking about this, 2013. We were all using the iPhone 5. Streaming was barely a thing.
Right.
And in medical imaging, the leap from 2013 to today, 2026, is just, it's massive. We're not just talking higher resolution. We're talking entirely new ways of seeing inside the human body.
That's the key. The technology outpaced the dictionary. Radiologists were using machines that didn't even exist when the last manual was written. They were seeing things the old book just didn't have words for.
So this isn't a typo fix. This is a foundational overhaul. And to guide us, we're doing a deep dive into this really insightful Beyond the AJR article. It's titled BI-RADS v2025, a welcome update.
Written by doctors Gene Seeley and Mary Bissell. And they do a fantastic job of highlighting not just what changed, but, why it all matters.
So here's our mission for this deep dive. We're going to unpack how this changes the literal words doctors use to flag cancer. We'll look at why they're banning food-based descriptions, which is fascinating. And we're going to explore this concept of harmonization. Because apparently, getting everyone to speak the same language is harder than it sounds.
It's the core challenge, really. When you have different specialists using different tools, communication can break down.
Okay, let's start right there. Harmonization. It sounds so lovely, like a choir. But what was the problem before 2025? Was it really that disjointed?
Disjointed is a fair word. You have to realize that breast imaging isn't just one thing. There's mammography, ultrasound, MRI,
Right.
and now contrast-enhanced mammography. And historically, these modalities, they sort of grew up separately. They were like different tribes developing their own dialects.
So wait, let me get this straight. A radiologist looking at a tumor on an ultrasound might describe it using one set of adjectives.
Right.
And then another radiologist looking at the exact same tumor on an MRI might use totally different words.
Precisely. And that's a nightmare for downstream care. Imagine you're the surgeon or the oncologist reading these reports. You want a consistent mental image of what you're dealing with.
And ambiguity is the last thing you want when you're deciding on a course of treatment.
The absolute last thing. So the big philosophy, the headline of the V2025 update is modality-neutral terminology.
Which means?
It means a mass is a mass,
Right.
Regardless of which machine took the picture. Whether you spot it on a mammogram, an ultrasound, an MRI, you use the same descriptors, range from least suspicious to most suspicious.
It's like standardized currency. You don't have to convert the description just because you switched cameras.
Exactly. It improves report clarity, it standardizes data, and crucially, it reduces the cognitive load on the doctors. No more code switching between machines.
Okay, so that's the philosophy. Now I want to get into the specific words because this is where it gets surprisingly specific. We have to talk about the food ban.
I knew you'd zero in on this. It's the most colorful part of the update.
How can I not? The source says they're removing informal food-based terms. I honestly didn't know radiologists were looking at x-rays and thinking about snacks. Is this for real?
Oh, it's very real. It's a time-honored tradition. For decades, if you saw a certain type of coarse calcification, you called it popcorn-like.
Right.
If you saw a sediment in a cyst, it was milk of calcium.
Popcorn-like. It feels so quaint, almost too human for something so clinical.
It is vivid. If I tell you something looks like popcorn, you can picture it immediately. It's lumpy, white, irregular.
Yeah.
But vivid isn't the same as precise. And in an era of precision medicine, subjective food metaphors are a liability. One person's popcorn is another person's cauliflower.
So the 2025 manual is basically saying, stop making me hungry, start being scientific.
Pretty much. They've replaced the snacks with physics. Popcorn-like is now just coarse.
And milk of calcium.
That's now described as layering. because that's what it's physically doing. The calcium is layering in the bottom of the cyst.
Coarse and layering. Okay, it's definitely drier. But I guess if I'm the patient, I'd rather my doctor sound like a scientist than a chef.
It reduces errors. Popcorn might not translate well into another language. Course does. And it's not just food. They've overhauled how they describe shapes, too.
Right. This is part of that harmonization. And I saw there's a comeback story here for the word lobulated.
Yes, lobulated is back in. It's been reintroduced as a valid shape descriptor.
It was gone.
It kind of fell out of favor.
Yeah.
But the committee realized they needed it. A lobulated shape has lobes. Think a cloud or a ginger root. It's distinct from just irregular.
Yeah.
So now there are 4 universal shapes for all modalities: oval, round, irregular, and lobulated.
Okay, so lobulated gets a pass. But I noticed another term was kicked out. Microlobulated.
Correct. And this is a really subtle but important distinction. Microlobulated used to describe the margins, the edges of a mass. But if you have a lobulated shape and microlobulated margin,
It's a tongue twister. A lobulated mass with microlobulated margins.
and it's confusing. Is it the shape that's bumpy or the edge? So to enforce clarity, microlobulated is gone. It's replaced with the term indistinct.
Indistinct, that just feels heavier, doesn't it?
It carries more weight. It tells the next doctor that the edges aren't sharp. They blur into the surrounding tissue. And that's a hallmark of potential infiltration. Indistinct flags the danger much more clearly than microlobulated.
It's fascinating how just editing the vocabulary can change the urgency.
Language drives perception. That's why these manuals are so important.
Now, speaking of things that didn't exist in 2013, the new manual had to make room for some new heavy hitters in the machine world.
Oh, a massive catch-up was needed. The 2013 manual was completely missing technologies that are now standard of care.
Like what are the big additions?
The 2 biggest are contrast-enhanced mammography, or CEM, and automated breast ultrasound. In 2013, these were niche, maybe experimental. Now they're fully incorporated.
And DBT, right, digital breast tomosynthesis.
Yes, 3D mammography. That's the standard now in many places.
Yeah. Right. And I read in the source that there's a specific rule change with DBT that really stopped me. It says a mass might only be visible on one projection.
This is a fascinating update. It really shows how much confidence we've gained in the tech.
Okay, explain that. Because usually, don't you need 2 angles to prove something is real on an X-ray?
Exactly. In traditional 2D mammography, the cardinal rule was triangulation. If you see a spot on the top-down view, but it vanishes on the side view, it's probably just summation of shadows.
Summation of shadows.
It's when normal breast tissue overlaps in a way that just looks like a tumor. It's a fake-out. So you wouldn't call it a mass unless you saw it on 2 views.
But DBT changes that game.
Totally. The camera moves in an arc. It creates a 3D reconstruction of the breast, slice by slice. You can literally scroll through the tissue.
So it eliminates that overlapping problem.
It significantly reduces it.
Sure.
So the new manual acknowledges that with this better resolution, a real cancer might actually only be visible on one view. The 3D slice proves it's real.
So they're trusting the machine more? They're saying if you see it clearly on one view with DBT, you can call it a mass.
It's a major shift in diagnostic criteria. It prevents radiologists from dismissing a real cancer just because they couldn't triangulate it the old-fashioned way.
That leads us perfectly into the ultrasound updates. And there's something here that sounds like it came straight out of a sci-fi movie. The echogenic rind.
It does sound sci-fi, the echogenic rind, but it's a very practical, very important feature.
Unpack that. What is it?
So imagine you're looking at a lesion on an ultrasound. A tumor usually looks like a dark spot, but sometimes surrounding that dark spot, you see a thick, bright, white border. That halo is the echogenic rind.
A white halo around the tumor.
Exactly. Now, radiologists have known for a long time, sort of as street knowledge, that this rind is bad news. It's highly associated with malignancy. But it wasn't officially part of the lexicon.
So you could see it and worry about it, but you didn't have a standardized way to code it.
Right. Now it's an official feature. But here's the critical part. The manual now instructs doctors to include this rind in their measurements of the lesion.
Wait, so the tumor size on the report is going to get bigger because they're measuring the halo, not just the dark center.
Right.
That seems hugely consequential.
It is. Think about how we decide on treatment. The size of the tumor often dictates whether a patient gets a lumpectomy or a mastectomy or chemo before or after surgery.
So measuring the rind could push a tumor from a stage 1 to a stage 2 just based on size.
Potentially, yes. By including the rind, the manual is ensuring the reported size reflects the entire area of disease, not just the core. It's a move toward more accurate staging.
It's wild that a small definition change in a PDF, measure the white line, can change whether someone gets major surgery.
That's the power of these guidelines. They dictate reality.
Speaking of which, I want to move to what might be the most controversial part of this. This is where our source authors, Dr. Celia and Bissell, raise a little red flag.
Yes, this is about time. The manual has removed descriptors that talk about change over time, specifically the term developing asymmetry.
Right, so developing asymmetry was when a doctor compared this year's mammogram to last year's and saw a spot that was new or growing. The term itself implied a history.
Exactly.
And the new manual says, stop doing that.
Essentially, yes. It's pushing for a purely morphologic assessment.
Okay, translate that.
Morphology means form and structure. They want doctors to judge a lesion based on what it looks like right now. Is it round? Irregular? Indistinct? They want to remove the time-based aspect from the description itself.
But isn't the fact that it's growing the single most important thing about it? If there's a blob that wasn't there last year, that's a siren.
And that is exactly the point the authors make. They warn that by removing terms like that, there's a risk we might underemphasize how a lesion behaves over time.
I'm trying to understand the logic. Why would they want to hide that information?
They're not trying to hide it, but they want to standardize the description based on physics, not history. Developing isn't a shape, it's a behavior. But Celia and Bissell are concerned that if you take away that specific label, the urgency might get lost in translation.
It feels like it puts more pressure on the radiologist's human judgment to connect the dots.
Absolutely. They have to describe the shape and then add the context that it's new or growing in their final recommendation.
So the story of the cancer, the movie of its growth, is harder to tell if you're only allowed to describe the snapshot.
That's a brilliant way to put it. We're prioritizing the snapshot over the movie in the terminology, and we have to be careful not to lose the plot.
Okay, let's shift to the high-tech stuff, MRI. The manual made some specific cuts and additions there, too.
Yes, again, it's about harmonization. For instance, the term focus is gone for MRI.
Focus always sounded vague to me. I see a focus like you're adjusting a camera lens.
It's vague. A catch-all for tiny dot. Now, those findings are categorized more strictly as either background parenchymal enhancement, BPE, or they're just small masses.
And multiple regions is gone, too.
Yes, that's also now described as BPE. They're trying to separate the background noise from actual tumors more clearly.
But they added T2 hyperintensity.
This is a technical but useful addition. T2 is a type of MRI sequence that highlights fluid. Adding this as a descriptor helps characterize things like cysts or lymph nodes, which can help prove something is benign without a biopsy.
And I saw a change that just sounds impatient. Initial phase is now early phase.
It's not impatience, it's physics. This is because of advances in ultrafast MRI.
Ultrafast MRI sounds like a superhero power.
It kind of is. We used to take minutes to capture the first pass of contrast dye. Now we can capture images in seconds. So early phase aligns better with these new super fast protocols.
It's amazing how the language has to run to keep up with the shutter speed of the camera.
It really does.
Okay, let's look at the administrative side, the so what. There's a new emphasis on something called method of detection.
This is really important for public health. The manual now requires mandatory documentation of how every cancer was found.
So was it found during a screening? Did the patient feel a lump?
Exactly. Was it on an MRI? A mammogram? By clinical exam?
Why does that matter so much? Is it just more paperwork?
No, it's vital data. By tracking this, we can prove the benefits of early detection. We can see statistically, look, these cancers were caught by screening before symptoms, and their outcomes were better.
It's the proof that justifies screening programs.
Essentially, yes. You need that data.
Now, there's a rule change for Category 6. And for listeners, Category 6 means known malignancy, right?
Yes, the biopsy is done, the diagnosis is confirmed.
But what's the new rule?
Previously, if you were doing a staging scan and saw another little spot nearby, it could create a dilemma. Do you have to biopsy that little spot too?
Which delays everything.
Exactly. The new rule is very pragmatic. It says you can allow for additional close findings within 2 centimeters without changing the category. Provided it doesn't change the treatment plan. If the surgeon is already going to remove that whole area anyway, you don't need to overcomplicate things for a tiny satellite lesion.
That seems like a mercy for both the doctor and the patient.
It lets the team focus on the main event. treatment.
And finally, report organization is getting standardized.
Yes. Every exam now needs a structured clinical indication. You have to categorize why you were there.
And the categories are?
There are three main ones. 1, asymptomatic screening. 2, diagnostic workup for a problem. And 3, diagnostic evaluation for a patient who already has breast cancer.
So no more guessing games. You know exactly why the scan happened.
Exactly. Context is king.
So putting this all together, we have a new manual that bans food talk, brings back old shapes, integrates space-age tech, and demands we ignore the history of a lesion in favor of its current shape.
When you sum it up like that, it sounds like a lot.
It is a lot. It feels like, as the author said, learning a new language.
That's the perfect analogy. And for radiologists, it is. They have to retrain their brains to stop saying popcorn.
So what's the bottom line? Why should you, listening at home, care about this PDF update?
You should care because this update is about precision. It's about modernization. It's about ensuring the fantastic tech we have in 2026 isn't being held back by terminology from 2013.
The software and hardware are finally talking to each other.
Right. And as Dr. Seeley and Dissel put it, this empowers radiologists to detect cancer more accurately and communicate risk better. Whether you're in New York or New Delhi, you're speaking the same language.
That consistency saves lives. It reduces errors.
It does. It makes the whole system safer.
But I do want to leave you with one final thought, something to chew on, pun intended. We talked about developing asymmetry. The manual is telling doctors, don't tell me what it was, tell me what it is.
Right. Pure morphology.
If the manual stops asking us to look at how things change over time, does that put more pressure on the doctor's individual judgment to spot those patterns? Are we risking losing the movie of the disease?
That is the provocative question. And it's why the human element, the skilled radiologist, is still the most important part of the machine. The manual is a tool, but the doctor is the artist who has to wield it.
A comforting thought for your next checkup. Thank you for diving deep with us today into the world of medical lexicons.
My pleasure.
And maybe next time, don't ask your doctor if your calcifications look like popcorn. They might not get the joke anymore. Thanks for listening. We'll see you on the next deep dive.